So yeah, thanks again for coming on the show. Our schedules are super busy. It's always hard to coordinate time. So I'm glad we found a good time to do it and appreciate your time. We'll call you Dr. Julie for the duration.
Okay.
But for those people that don't know, can you just kind of give a little brief background of your history in emergency medicine?
Absolutely. Yeah. I, I don't know that a lot of people know that I actually started off in EMS. So I went to college, did all my pre-med stuff. And part of what I did was I worked in the hospital. I worked as an EKG tech.
Oh,
And I saw like this disconnect between the way that people wanted to be when they went into medicine and how they really were when they had gotten there. Just like the unrecognized burnout even at that time. And
yeah.
I didn't want that to be me. And so I'd majored in biology and I thought, oh, I'll work for the state park. So it ended up being a really fun gig. So I was at 11 Mile, working at 11 Mile, and lived at Mueller before they developed Mueller, with like 4 or 5 other young people. Most of them were on the park ranger track, but it was super boring in Divide in the winter. So the Park Service would pay for us to do first aid classes. So one of the ranger track guys and I did American Red Cross Colorado Springs first aid class. Loved it. I did the EMT class. I think he did too. Loved it. And then I started working and it was a seasonal job anyway. So I started working for Mountain Valley paramedics at that time. And then it got taken over by A1. And the best job I've ever had in my life. Honest to God, it was just so fun. Because there were the challenges, there was the teamwork. It was a big family, really, a camaraderie, and then just a lot of challenging, interesting stuff that I hadn't really seen before. So when I went to medical school, I kept it, and then I decided I wanted to go into medicine. I kept an open mind about my specialty and what I'd want to do. But, the adrenaline junkie part of myself, just there's nothing better than driving the wrong way down Academy lights and sirens, So that part of me was still alive, and I've loved emergency medicine. It's been a great career.
That's awesome. That is a lot of emergency physician stories as they start in EMS. I didn't know that about your story, even before it was A1. I mean, that's crazy.
Yeah.
I mean, that would have been definitely the first ambulance company, probably in the Springs, I would think, or one of the first.
I think it was, yeah. So they changed the name to Mountain Valley, but it actually started as Fountain Valley and started in Fountain. And there's, anyway, there's a lot of crazy twists and turns to the EMS stories in Colorado.
Yeah, back then, yeah. I mean, EMS has evolved so much in that period of time. So what year would that have been that you worked on the ambulance?
So it was like 81. Okay. So I graduated from undergrad, I think 81 in the winter, and then so it would have been like 82.
Okay.
But then I started med school in 83, and I actually worked on that weekends still. Part-time. I could come down, and at that time Colorado College had a football team, and so they just put me on the car that did standby for Colorado College football teams, and I could study. It was a really nice gig. They were very good to me. Yeah.
So what year did you become an attending?
I came back here in 91.
91. Okay.
Yeah.
So I mean, give or take 40 years.
40 years
in emergency medicine.
Yeah.
Plus, if you include the EMS time. I mean, that's more than most people I ever work with. And you and I haven't worked a ton of shifts together. Like, our schedules are all crazy. And sometimes certain physicians I don't work a ton with the exception of like the last few months, we've had a few shifts together. Mm-hmm. And I was really struck by like just some of the off the cuff insights that you have when you're talking with nursing, when you're talking with the PAs, when you're talking with the patients. Are really incredible and just kind of speak to your experience level, I think. And your level of gestalt, I think at your experience level is like unmatched. I mean, you've seen so many patients at this point in your career. You pick up on things that are super subtle that I'm just beginning to probably pick up on patients. And so that was really interesting to see and really struck me. And so I was like, I really want to talk to you more about this, because we just don't have time on shift to discuss anything of depth. We're really talking about the patients because that's what we have time to do. And so I really wanted to get your opinion on things more. I wanted to lead off and just kind of ask you about what it was like becoming a physician in the early 90s, when I looked up some statistics, but it was really like 10% of women were physicians compared to the 90% of men that were becoming physicians. And so I imagine that was a whole dynamic to contend with. So I wanted to kind of see your thoughts on that whole aspect, because I imagine that was really challenging.
Yeah, I think it was actually more challenging in EMS. And then when I was in residency, my medical school class was 50% women.
Okay.
But they went into the traditional female specialties. They went into pediatrics, psych, internal medicine. Nobody in the procedure-oriented specialties, especially surgery. So yeah, when I got to residency, it was, there was like one woman a class in the classes before me, and there were two of us in out of 12 in my class. So it was, it was definitely a situation where I was outnumbered, but I was kind of used to it after EMS, really.
Sure.
So.
Yeah, even I think when I started in EMS, it was mostly men, and that's rapidly changed. I mean, all the specialties I think have rapidly changed. My PA class was mostly women, and they've been having that for years and years. I don't really know what causes that, but it seems like there's much, much more women. But what's like some of the big changes you've seen in emergency medicine? Is there anything that sticks out that's really changed in 40 years? I mean, everything, I'm sure, but
yeah, I mean, literally everything has changed. I think it went from people had a primary care doc and they really only came to the ER either for an urgent care thing that they couldn't see their primary for or a real emergency, to diagnosing cancer in the ER. I mean, I never did that the first 10 years of my career. So that's been a challenge because we don't have that relationship like their primary care doc would have, and that's a hard thing.
Yeah.
On the other end, there was one of our coroners that said, "Don't bring in people that you've tried several rounds of drugs and cardiac arrest for," and so that really transformed things because the paramedics would be doing like half an hour of ACLS on a patient, bring them into us, we'd do another hour. So, I mean, it was exciting if that's what you like to do is resuscitation, but we didn't really bring, anybody back. I think it was a great call on the coroner. But so it really felt like when I started, we did more emergencies.
Yeah.
So, yeah.
Yeah. One thing I think is kind of a cool thing about emergency medicine is that we step in to fill all the gaps in the medical system, which is pretty gratifying. I mean, it means, we're not just dealing with emergencies anymore, but patients that are worried about something can't get in with their primary care. We're there to reassure them. Maybe they don't need anything done that specific day, but we're there to just educate them and reassure them that what they have going on can wait to see a primary care provider. And we do plug all the holes, any of the deficiencies in getting in with primary care or bad urgent care hours or whatever it is. We plug all those holes, which is kind of satisfying in its own way too.
It is, and I think that when I first started, there was this almost a contempt for the people that don't really have emergencies that are, calling or showing up. And now it's nice that there's a little bit more empathy about the, hey, I know, you can't get in to see. And, you called 3 phone lines and you just got, a recorded voice. I mean, this is a way you can access a human being. So I'm fine with that. With people coming in for what maybe we wouldn't have perceived was an emergency when I first started.
Yeah.
But, I mean, the other thing that's really been dynamic is, I think, transparency in medicine, so it used to be that, there was this top down, bottom up, hey, I'm the doctor. This is what I recommend. This is what you should do. And now, and then the whole change of, oh yeah, we should have interpreters. We should actually get a consent for the procedures that we're doing. We should make the electronic medical records available to patients. I really applaud all that. I mean, I think that relaxes the communication and makes it more honest.
Yeah, I think that was something I didn't really appreciate when it first started, especially now that our patients can see their labs instantly, their imaging instantly, our charts as soon as they're signed. For me, it was frustrating initially because you have patients asking you about every little lab, but I think it helps regain some of that trust that I feel like waxes and wanes depending on different cultural things going on in the world. People lose trust in the medical system at varying times because of things that are going on. And I would imagine you've seen that kind of go up and down because it kind of goes on the whims of whatever's going on in the culture. And so I agree. I think the transparency is super needed so that we can gain that trust in a very short amount of time that we have with patients. And then they can ask their questions on their lab work, and you just kind of get in that mindset when you know they've got their labs pulled up and there was some abnormalities that to us don't change anything, but they're concerned about. You pull up a chair and you're like, let's talk about these labs real quick. Let's all explain all the reasons why I'm not worried about them and what they might mean. And you need to follow up with your primary, things like that. But it does allow us to build that rapport, I think, with patients. Instead of them kind of going home and looking at all their stuff and then stressing about something that they shouldn't stress about.
Right. Or they have the wisdom like, yeah, my white blood count has been elevated for the last 10 years. So, don't you worry about it.
Yeah, that's a good point too.
Yeah.
Did you have any specific mentors when you were going through med school or residency that spoke to your life and kind of helped give you good mindsets going into the ER?
One of my best mentors was actually a female paramedic that I worked with at Mountain Valley named Lisa Carl. And for anybody out there that remembers Lisa, she's still alive, but she's not working anymore in EMS. But she approached her patients in a very empathic manner. She was still, a really good paramedic, and eventually went on to work for Denver General. At that time, it was not Denver Health, it was Denver General. But I just loved the way that she was very human with people. She reassured them. She met them as a human being. And I didn't see that in a lot of the other interactions that I saw. So I really took a lot from her example, and she's a great friend. And then Marilyn Gifford, when I came out, was larger than life, but just very inspiring. But she was really good. Yeah, there weren't really a lot of good female examples in med school or residency.
Yeah. So. Yeah, I imagine that can be hard too when you're trying to see yourself and your mentors. But I had similar experience when I was brand new to EMS, and those people really can make or break your trajectory. Because I can remember partners I had that had terrible bedside manner, and I would start to adapt to their practice, and I would start to not take patients seriously and not do my job well. But then I would have a partner that did all the things right. They were thorough. They didn't pass on their bias in the handoff report. Even if we thought the patient's not dying, we don't think this is an emergency, we can't believe they called 911, he would still take them seriously. He would do all the things you need to do and give a great handoff report. And he pulled me aside, and, when I would give some bad handoff reports, whether it was writing off the patient or, people that are new in EMS, I think are very prone to do that. When you get 6 months of experience and you think you've seen it all, you think you know everything. And that's that dangerous part of kind of that learning curve where you're brand new, you think you've seen it all in 6 months, and then you're kind of dangerous for a period of time until you've maybe gotten humbled a few times. And he was one of those people that helped me with that curve. He's like, hey, Aaron, your handoff report was ridiculous on this patient. You didn't take them seriously. You didn't check the things you need to check. I know you're trying to be funny and, you're trying to be lighthearted, but at the end of the day, you need to do the right thing for the patient. And he completely stopped what was probably a really bad trajectory for me. And, of course, in the moment, I'm sure I was indignant and I was like, oh, I'm fine. I'm hilarious. But then when you get self-reflective, you're like, oh man, he was actually really right on and had the courage to actually tell me that. And looking back, like those things are really small, but probably changed my trajectory in medicine substantially. Because I mean, you really realize how much you don't know at a certain point, and it takes people sometimes a long time to get to that point where they realize they don't know everything, and you're kind of dangerous at any level until you realize that and start taking people seriously. And so mentors, I think, are huge.
Yeah. Yeah, I even see that with the staff in the ER. It's interesting to see the relatively new, sometimes, EMTs or nurses that'll kind of just tend to start off with their first comments are derogatory towards either the patient's presentation or, something. And it's really hard to bring people around. But I think that if we focus on that, you just can't go wrong if you're trying to do the right thing for the patient. I mean, I suppose you can, but you're not going to go way off course, and that's the anchor that I just keep coming back to is, okay, golden rule. What's the best thing? What would I want done for my family member? What would I want done for myself?
Yeah.
And to bring that back. And because we're all ridiculous sometimes,
sure.
Right? We all say and do stupid things. We make bad choices. How do you bring that back and wrap it back up and try to help them make it right?
Yeah, I think that's a great point. I think it's a common mistake to, the meth addicted patient or the alcohol intoxicated patient and see them as somebody with poor morals and they've made all these bad decisions, kind of realizing that we're not as far from that person as maybe we think we are. Any of us are maybe just a few bad decisions away. You don't know what happened to their life. And I think if you kind of understand that, I talk about this story a lot, but I had a ER physician that I interviewed on here from out of state, and he lost his kid at 9 years old to a chronic illness, and he was devastated by it, started drinking, realized that he couldn't show up intoxicated to work, and turned to opioids and was prescribing them for himself, using patient names, got found out, lost his license, and ended up homeless, still addicted to opioids. And he ended up getting on Suboxone through a physician friend of his, and he was able to completely rebuild his life. He's a leader in one of the hospitals he works for. He's back in the ER. But it makes you realize, like, if that can happen to him, it can kind of happen to anybody. You just don't know what life experience someone has had. And it's not a lack of morals or discipline or whatever. It could happen to anybody if you have enough bad life situations happen to you. And I just think that made me have so much more empathy for patients that are struggling with things, because you're like, I'm not that far from you, and I think that helps. And that helps you not miss things and take them seriously when they come in too.
Yeah, it does. Yeah. It's so I volunteered for a while at Mission Medical, and some of the same people that we see in the ER go there, but they're sober. They show up, and so I saw one of them at Mission Medical who was just really very kind-hearted, and then the next time I saw him in the ER, he was just a raging jerk, and I said, I'll call him Bill. Bill, you're better than this. Mm-hmm. And you know what? He stopped. He turned around, because he knew he was better than what he was doing.
Yeah. So. You, before we talked, you sent me, I believe you were some kind of instructor for a paramedic class at UCCS, and you sent me like your introductory comments to them, using the 7 Habits of Highly Effective People as kind of the framework, which is one of my favorite books. I think I have it here somewhere, but one part that stood out to me. Yep, there it is. Yeah, it's a phenomenal book, and there was a point on there that relates to that I wanted to talk about. Where was that? Oh, yeah. I mean, one of the 7 habits is seek first to understand and then to be understood. And you talked in kind of your introduction to these paramedics about how if you seek first to understand the patient, even the psychotic, high on meth or intoxicated patient, if you try to figure out what they need first, you can often de-escalate these situations substantially just by trying to figure that out. And I think that's a great point that so many of us miss is trying to figure out what do they want in this interaction? What do they need? I think that's huge.
Yeah. That's actually part of the whole, de-escalation training too, that they do with the hospital when they, teach people. But yeah. We had for a very brief time, a degree program through UCCS with paramedics in Bethel. But there were issues and it fell apart. But yeah, so I was physician advisor for that. That was fun.
Yeah, that's cool. I didn't know UCCS ever had that. I got my degree through UCCS, and they were able to take my paramedic and use it as credits, but I originally got it at Pikes Peak. But
good.
Yeah, that's interesting. They had a paramedic program back in the day.
So there was one of the things that you addressed in the questions that you sent to me that I would love to just speak on if I can. And it was about, what was it like to be a woman, and what is it kind of like to be a minority? And I obviously am not an ethnic minority, and so I can't speak to that, but I can speak to having your voice dismissed and ignored, which was mostly what would happen with that. It wasn't usually an active kind of although there were some people that would just come in and kind of in an undertone make derogatory comments. But it was mostly just, if your hand is raised, getting passed over all the time. If you had comments, what I would have to do in our meetings would be to tell the ideas and see if I could get buy-in from one of my male colleagues that I knew was in agreement with me and have him present those ideas. And, so I would put my hand up, would not be called on. His hand would go up, he would be called on, and he could present the idea. And I just couldn't own it, but like I couldn't have that. And it's an ego thing of saying, yeah, I was right. That was my idea. So you just had to like throw it out there. But I see that happening and people getting very frustrated with it, I think, when they feel like they're disempowered. I see that too, and people being dismissed. I see that with the APPs. I hear them on the phone with some of the attendings, and I hear them get that same kind of dismissing. And it's too bad. It's too bad that happens. So
yeah, that is something I have noticed as a PA. You're not a physician, and when you're coordinating care with a specialist of some kind, they are a physician and maybe feel a little more licensed to talk down to you. And sometimes I don't think their intent is necessarily bad. Sometimes they just want to educate you because they know I didn't do an ER residency. Most of us didn't. They know that some of us are brand new out of school trying to learn how to do ER medicine. And so sometimes I think their intent is to actually educate you on points, and maybe their affect is not the most tactful with it. And then sometimes maybe their intent is not to educate and it's just to prove they know more than you. But yeah, I mean, we all deal with that to some degree. Yeah.
So, but yeah, anyway, it's good now, but yeah.
I even still see occasionally, the patient, I go in after the female physician has seen him and they're like, I haven't seen the doctor yet. I'm like, no, I know you saw the doctor. That was not your nurse. And I think that it becomes less and less common for sure, but I still see that. And so it's still like a dynamic that's at play that just makes work a little bit harder, I think, for females. It's a little thing, and, you probably gloss over it, but if I'm noticing it, I'm sure the women are noticing it. So it's still a dynamic that you have to wrestle with, I think. And yeah.
Probably especially the first 10 years of my career as an attending. Sometimes I would say, hi, I'm Dr. And, and then people would say, well, they would ask me, when's the nurse going to come? I mean, when's the doctor come in? No, I'm actually the doctor. And I had this little button during residency that said, life is a constant audition. And I mean, it almost felt like that, you're just like, always having to prove yourself. But it was really funny. Then we started getting a lot of male nurses in the ER, and actually a lot of us just enjoyed the joke of, we'd go in and people would get it mixed up. Be like, no, you got it mixed up, Yeah, he's the nurse, I'm the doctor, but that's okay.
That's probably a good tact, is to have a little sense of humor about it instead of, because we all struggle with taking things personally. And I think if you are apt to take things personally, it just leads to burnout. And if you can have a sense of humor about it and, realize that no one's attacking you personally most of the time,
right.
That's probably a good way to get past it and not ruminate on something that's going to really make you burned out in a field that's already prone to burnout.
Yeah, you can't. But actually, I've probably had 20 older ladies tell me to my face that women can't be doctors or pilots or whatever, and I just thought, well, so they must have had that message given to them with their dreams that they gave up, So,
kind of projecting their life story onto you.
Yeah.
That's
like,
too.
Well,
that's
it
too
can't
bad.
be. Well, I am. Okay, here we are. So yeah.
And that kind of leads me to the topic of burnout, which is what a lot of this podcast centers on: is how do you maintain longevity in a very difficult specialty? And you're probably the most equipped to speak on that of anyone I've had on here. Is what kind of mindsets or things do you do to survive and actually thrive in such a difficult specialty that's very prone to burnout, very prone to people moving jobs frequently to try to fix things? Can you speak to that?
Yes. Yeah. I've actually done a lot of work on that. So, I had one really horrible, and I won't give you the details because I don't want people to get secondary trauma from it, but I had a really horrible child abuse case that was actually the biologic dad, which even makes it worse in my mind. And it took me a really long time to process. I mean, it's just one of those things that, not even so much of a PTSD kind of a thing, but it was the moral injury kind of thing that they speak about with burnout. Got counseling. I did, called friends. The thing that helped me the most with that is this very ancient kind of amygdala reset that's called a labyrinth. And so they have some in some of the older Catholic churches, but they're actually pre-Christian. And you just kind of trace a path in and out in a very deliberate manner. And it just kind of resets your amygdala, which is the part of our brain that does, all the fight, flight, freeze and the trauma memories.
Like it's a physical act of like drawing on something, or?
You can draw. They do have some that are drawing, but you can walk on a path. There's one downtown outside of what used to be First Christian Church. That's one of the big non-denominational churches now.
Okay.
They have them, I've been told, at some of the Catholic hospitals have them too. But it just, I think getting to something like that, or a meditation or yoga, or whatever works for you, really helped me. And also spending as much time as I could outdoors, just really reset. But I think that you have to have some kind of a creative outlet, some kind of a spiritual outlet, whether that's organized religion or meditation, or just some awe and gratitude practice, I think is huge. And every time I feel like I am just like so up to it and so burnt out, it's that whole, and they've done studies on this, like if you just have a moment of awe, like you go outside and you look at Pikes Peak and you say, wow, that kind of helps to reset. And then focusing on the patients, trying to get the best outcome. But I've been very burnt out probably 3 times in my career. And our group has a 1-month sabbatical that we can do. That's huge. Just getting a couple weeks away from work, I think is really huge. And then, and having some other part of your life,
Yeah. Using that benefit, whether it's PTO or sabbatical, whatever it is, to just get some space, I think is really helpful. It opens up your mind, I think, to think in ways maybe you can't think when you're in the, you're in the grind and you're seeing patients regularly. And yeah, and I like the getting outside. A lot of people mention that because I think it just helps you kind of put things in perspective and helps you get past certain things.
It's also, like if you get a little bit of time off and you see the world through what your neighbors probably see the world, so my neighbors don't really know that meth exists in the city like you and I do.
Yeah.
They just don't experience that every day.
Yeah.
And it's hard to come across all the effects of addiction and the ways it wears people down. And so sometimes I think it's good just to get a break from that and say, hey, not everybody has to see this every day. And I guess maybe that's a little bit of denial, but I think sometimes it's just good to get a break from it.
Yeah. Yeah.